Everything rises and falls on leadership. The ability to lead well is fueled by living your cause and purpose. This podcast will equip you with the tools to do just that. Live and lead with cause and purpose. And now, author of the book, The Anatomy of Leadership, and our host, Chris Comeaux.
Hello and welcome. I'm excited. We have two incredible guests today. We have Tim Rogers, who's the president and CEO of AHC, and Paul Ledford, the president and CEO of the Florida Hospice and Palliative Care Association. Welcome, gentlemen. It's so good to have both of you.
Great to be here. Thank you.
Absolutely.
Yeah, let me read from Paul's bio and then Tim's bio. So Paul Ledford grew up in Tallahassee, Florida as a graduate of FSU. Go Noles, Paul. My wife's a graduate as well. And he was in the College of Business there. His career includes service as a government administrator and regulator. And since 1995 as an association executive. He is a certified association executive and a designated professional lobbyist. In 2004, Paul joined the Florida Hospice and Palliative Care Association as the president and CEO. He is a past member of NHPCO and the HAN Board of Directors and past chair of NHPCO Council of States and currently serves as the Alliance Assembly of State Associations. And Tim Rogers is the president and CEO of the Association for Home and Hospice Care of North Carolina and South Carolina Home Care and Hospice Association. And Tim has held this position since 2001. Tim served 9+ years in the home care and hospice industry, starting at AHCA 1992 as a director of government affairs. And he's also served in key C-suite positions for two large, duly certified Medicare home health and hospice agencies that were serving North Carolina and South Carolina from 1994 to 2001. And you look at him, you swear he's still 30 years old. Tim is a graduate of UNC Chapel Hill with a BA in political science and history. And he has additional work experience and positions in State Employee Association of North Carolina, North Carolina Bankers Association, 1983 to 1992, and just a wealth of amazing position and experience throughout the country and a state and political level. So, gents, Paul, maybe you first. What did I leave out that maybe you'd want to?
Yeah, I think the bio pretty well covered it. I've been involved in government affairs really since 1984. I'll put that on my resume, but got involved early in presidential campaigns and before, while I was still in college, actually.
Awesome. Tim, what about you? What would you want our audience to know about you besides all that great stuff in your bio?
Well, I'm going to congratulate and echo my friend Paul. We have a lot of similar background. I started in about 79 to 83 in politics at UNC Chapel Hill. I'm the son of a county sheriff, elected official. So I got really interested in that and started going into the home care and hospice industry, as you said, in 92. But I tell you what also lately has been great is I've been able to work with Paul and other state execs across the country, and I'm the coach of the Alliance for Care at Home, Assembly of State Associations, and we've come a long way, and I just have the utmost respect for you, Chris, and the utmost respect for you too, Paul.
Yeah, well, both of you just
appreciate that.
Hats off to both of you. In fact, I have to tell you where the idea of this podcast came from. I know Paul probably knows Mark Cohen. So Mark was a long time, worked for Vitas in Florida and has done a lot of consulting. And he shot me an email, said, you need to do a podcast on certificate of need. And I was already thinking about that concept, but it really kind of pushed me over the edge. And then immediately I thought, man, if I could get Paul Ledford and Tim Rogers on a podcast together, that would be incredible. So I reached out to both of you. Tim was out of the country, and then it just all fell into place. So that's what we're going to talk about today, certificate of need. I think this is a really interesting time. States that still have certificate of need, there's a lot of opposition to try to get rid of it. So why don't, if you guys are okay, let's just go ahead and jump in. So there may be some listeners who may not live in CON states. We're going to use that abbreviation throughout the rest of this podcast. What problem was certificate of need originally designed to solve in healthcare? And why does hospice still raise those same concerns today? Tim, why don't you take it first and then Paul?
So to me, I think it's kind of ironic that some of the rationale and the reasons for starting CON way back in the 60s and 70s, it actually was a concept that came out of UCLA in the late 50s. I read a great paper about that. Is that it was started to control cost, duplication of services, ensure efficiency, control capacity, and improve access. Well, I argue those same reasons exist today in CON states. And I've got 30 years in my belt that knows that North Carolina is a CON state. South Carolina is not. So I know the best of both worlds. It's a tale of two cities. But through the 70s and 80s, and we know it was repealed in 87 by the federal government and it was left up to the states. So now we find ourselves in the issues of who's eliminating what, when, and where.
Well, and we're going to get to a lot of great discussion about differentiation. But Paul, how would you answer that?
Similar. It's to address cost, access, and quality. And it's also prudent for the government to control who they pay money to. If you look at managed care, and like in Florida, Medicaid is 100% managed care now, and they control how many providers there are. And it's the same thing with hospice. 95+% of funds come from Medicare or Medicaid. So it makes sense for them to control who's providing those services.
That's well said. I've been involved in several CON fights and trying to help educate legislators of why it's a good thing. And quite often, folks that may come from more a free market standpoint and say, well, CON is just, anti-competitive, right, and it's not in line with free market. So what's different about hospice maybe compared to other parts of healthcare when it comes to market forces? Why don't you take that first, Paul?
Sure. Well, the first thing I think is the criteria. The 6 months are from death and the normal course of the disease, and foregoing curative care. So that's completely unique to any other sector of healthcare. Also, the daily per diem that hospices are paid based on the level of care. I think that's another very unique feature. I don't know of any other sector of healthcare that does that. And what sets it apart from lots of other sectors of healthcare is that the elements of the free market are not there. And let me expound on that a little bit. Price and rate are set by Medicare, and that applies to Medicaid as well. There are no copays or deductibles paid by the patient, also a very unique situation. And the other free market elements missing are the flexibility in demand based on price or supply. And that's because demand is shaped by demographics of the area. So 2 of the 3 fundamentals of the free market, price and demand, are inflexible, and supply is the only part of that principle that is flexible. So it's designed to fail if you think the free market's going to control the factors.
That's well said. And also in many states that don't have a CON, the supply almost kind of far exceeds the demand in many cases. And I'd almost even maybe amend that statement I just said, because sometimes they will cherry pick the population they serve, and they will not serve all the population. And then you don't end up with everybody. The idea of free market is, well, then you're going to meet all the market demand. That's not the case. It's not 100% homogenous throughout the country. Tim, anything you want to add to that?
My esteemed colleague described it well, and I think along the same line. It's not like having a Starbucks on every corner or a McDonald's on every corner. You don't need a hospital on every corner, and you surely don't need a hospice on every corner. And his theories, and Paul, your analogies I totally agree with. And you said it wonderfully. I know, it's just in North Carolina, we have all these things built into a CON process. And I should have started by saying my mantra is, if you've seen one state CON program, you've seen one state CON program, because we're all different in some ways. But in our state, it ensures competition. It demands that you talk about access in your application process. And your county is your service area. So you're not going to be able to cherry pick as much, because you've got to be able to serve and tell the state of North Carolina you're going to serve that service area, that entire county, not a certain demographic or a certain way of life or certain assisted living communities. It's just pretty much cut and dry, and the fact that it's regulated, and that's what I like.
Tim, you remind me just something of what you were just saying. Many years ago, we worked on a project. I'll leave the city unnamed, but it was a big city in South Carolina, which, as you said, has no CON. And the hospital hired us because there were 55 hospices serving that region, and they asked us to take those 55 down to 4 preferred providers. And this is the story that kind of pushed them over the edge to do this project. 2 hospice reps got in a fist fight on the hospital floor trying to be the first one into the patient's home. And that was the moment the hospital said, we've got to do something. This is kind of beyond ridiculous. And it just breaks your heart.
Yeah.
Wow.
Yeah. Well, let me ask you guys another question. So advocates for eliminating CON, they often argue that removing regulation just increases access and improves quality through competition. But then we look at states with no hospice CON. Do we actually see that being the outcome? So, Paul, why don't you take that one first?
Sure. I've recently seen data that shows there is a correlation between CON and access in rural areas. It's not as clear cut generally. And for example, Florida's number 3 in overall utilization, according to 2024 Medicare data. But we have 4 times the utilization rate in rural counties than a state like Texas, which is number 12 in overall utilization. California is a perfect example with they're number 41 in utilization. And they have 11 massive counties with 0 hospice. And then also, Florida has the highest utilization by minority population. It's far above the national average, which I think is a great access indicator. Quality is a different animal, and it's a more difficult question because participating in quality measures is optional. And a state like Florida has 100% participation in quality hospice measures. And many states, particularly those 6 states on the CMS Special Focus Program, have a small fraction of their hospices participating. So it's not an apples to apples comparison on quality.
That's well said, Paul. We just taped a podcast with Bob Tavares and Cord Kastner around measures that matter. And 30% nationally actually report quality measures, patient family satisfaction, the CAP survey, 30%. So 70%, some choose it willfully, some are too small. And the fact that you guys have 100% participation, that's pretty awesome.
That's good. That's great.
That's real. And I was thinking, whenever you said about California, 11 massive counties, you meant by like square miles, right? Very rural, big, not necessarily like not LA you were referring to.
Yeah, no. If you look at the California, they actually have an association of rural counties. It's pretty much all those. They're big agricultural. The east side of the Sierra Nevadas, it's the middle of nowhere. But square miles, they're massive counties. And people do live there.
But they're not getting the care. Wow.
But there's 2,200 hospices in California and growing. And there's more hospices in LA County alone than the state of North Carolina. So those are some contextual things to put in your mind. Paul said it fantastically. I just want to say one thing about access too. In North Carolina, we have 100 counties, Paul, and we have a hospice office in nearly all, if not all, one or more in each county. But however, those counties are served on average by 10 to 20 different hospices.
Wow.
Some counties in North Carolina, large ones, Mecklenburg and Wake, have 28 and 30 providers of hospice and or home health services. But you look to South Carolina and Horry County in Myrtle Beach, 60 and growing. 60 hospices in that growing beach community. And we've had tales of oncologists and other doctors say, stop coming to my office. I don't want to hear about you anymore. And what that does is deflates the hospice beneficiary experience and the entrance into hospice.
That's well said, Tim. One of my board members in a board meeting, we were talking about some of these challenges, and he kind of said, "Oh, it's the Willie Sutton rule." And I said, "Excuse me?" He goes, "You've never heard the Willie Sutton rule?" I said, "No, sir. I'm sorry." And then he educated me that apparently Willie Sutton was a bank robber, and they asked him why did he go to the banks to rob the banks, and he said, "Well, that's where the money is." Unfortunately, why do these metropolitan areas get all the conglomeration? It's easier pickings to try to get those patients. And then the rural patients, it is much harder to reach them. So they kind of go where it's easy, if you will, and creates an oversaturation when you don't have a CON in place. Would you guys push back on that or say it maybe slightly differently?
No, they're definitely going to go to the urban populations where there's people. And if they're engaging in fraud, they need to come up with Medicare numbers from somewhere. And so if you have a large homeless population where you can go literally buy Medicare numbers from people, that's how they do it. you can't do that in a rural community. But the local sheriff will throw you out.
Or it's harder to do it in a CON state.
Right.
Well, another area, in most states that don't have a hospice CON, you see more providers, but for fewer patients served per provider, which is what we're kind of saying here. So from you guys' perspective, why is that a problem from a quality care perspective?
Well, I'll just say this. I mean, there are more states without hospice CON than with hospice CON. In fact, 86% of hospices in the United States are in non-CON states. I don't think that's good. And, I think the research does say that it translates that fewer patients can be served. And in fact, data also says there are lower utilizations and challenges with the fragmentation in these states. And does that equate to quality of care? No. And actually, I'm going to quote my friend here. My good friend Paul was interviewed in Hospice News. I read it, Paul. And you said a lot of things about ways to safeguard bad actors and malfeasance in the hospice space. And the absence of such policies like CON and licensure heighten those risks around fraud, waste, and abuse. And I concur with you that the states without CON are seeing the majority, not all, the majority of unscrupulous people trying to get into the space, the sanctity, the best benefit in the Medicare program, the hospice benefit, and that's troublesome.
I think economies of scale are important. Like in Florida, we have big hospices. I think the average hospice in Florida is roughly 10 times the size of the average hospice nationally. And that's an old number, too. It's probably more than that now. If a hospice is at the hovering near the break-even point, they're going to be struggling to keep the doors open. So they're not going to provide as wide a scope of services or be as flexible with staff. And then the other piece is the larger hospice program is going to they're going to have a lot higher capacity to train and mentor their team members. They're going to have significant technological and community support advantages. And you lose all that if you have 70 or 80 or 100 hospices or 350 hospices in a town. There's no way you have those elements present.
I just want to add to that, Chris, if I could.
Yes.
Paul, that's another one. You're exactly right. In North Carolina, we're fortunate, like you are in your association, to represent nearly every hospice. We represent 98% of the hospices and home health agencies. So I get a lot of feedback data from that. And also just the fact that in those non-CON states, you're going to see really, really more problems than cherry picking. And I know we've talked about that before, but everything you said earlier was just on target. I think there's a lot of similarities in some ways to Florida and North Carolina. I know our methodologies are a little bit different, and our methodology is evolving. Chris can tell you that. It's changing thanks to I, and others. So be interested to see what happens.
You both just reminded me. So two personal experiences. I love my godfather. He is a serial entrepreneur, and we hadn't seen each other in quite a while. And I was working in Texas, so we went to dinner, and we were catching up. We hadn't seen each other again, probably maybe 20 plus years. And I was explaining to what hospice was and how I'd been. This is my career. And he sat back for a second. And he goes, "A lot of people dying. That's a great business. I need to look into that." I'm like, no, it's exactly kind of part of the problem is that. And the other example is, I will leave the state unnamed, but we were working with a very large home health and hospice program. And the CEO asked me if I would do due diligence with them. And we went and did due diligence of this hospice. And I kid you not, you were interviewing the owner, and he was an elk hunter. And that was his qualifications. And his grandma had gone through hospice, and he thought, hey, this is a great business. And within 2 hours, the compliance risk, it was awful. And then what his expectation was for the sales price. And this is one of many that were in that community. And I just thought, and this is what's wrong with hospice. There's nothing wrong with an elk hunter, but I mean, this is a very complex modality of care, the regulations, and then someone was like, oh, well, just a lot of people dying. It's like a car wash, or like Tim, you alluded to, or like a gas station or something.
Well, I was going to say that about a gas station. And I was going to say, you're exactly right. We have those people now in hospice. People with no healthcare experience, no knowledge whatsoever. And I use the analogy, it's not perfect, but I use the analogy in North Carolina with Medicaid home care. Years ago, we have licensure. Every facility starts with home care licensure, and home care, home health, hospice. We always had strong licensure, but not strong enough. We had agencies that had oxygen in the gas stations and wrecker services, and people did not have owner qualifications, didn't have this, didn't have that. And in North Carolina, where CON is regulating this and requiring that, finally, North Carolina licensure has done something similar to Medicaid, except a moratorium or certificate of need. We have 246 hospices. We have 3,100 licensed home care agencies.
Wow.
With no moratorium, no CON. That's just a little bit of an analogy of where I think another aspect of where CON can work and has worked.
Well said. Well, let me ask you guys this question. What do deregulated states teach us about the unintended consequences, such, we alluded to this earlier, cherry picking, market-driven admissions, or reduce investment in those rural complex patients? Paul, why don't you take that one first?
Sure. Well, I think diminished service to rural areas is probably top of the list. Fraud's probably top of the list, but that doesn't happen everywhere. So we'll start with rural service. CON in Florida requires the hospice serve the entire service area. So some of our service areas are multiple counties. So you may have an urban area and some very rural areas around it. That's the way it is in Tallahassee. We have the Big Bend, if you will, is a city with a bunch of rural counties around it. And if you get a CON in this service area, you have to serve it all. It gives you the patient mix. In a CON state, every unserved death essentially counts against the entire service area when the agency runs the formula. So chronically ignoring an area or a disease state, if you will have an effect. And then the last piece I would mention is in a non-CON state, there's no requirement and no incentive to serve a remote or complex patient. There's also no consequence for not serving a remote or complex patient. And I think those are huge.
That's very well said, Tim.
Same here, Paul. We have to serve the entire service area. You have to make that known in your application. Our service areas are our county, but you can serve more than one county, typically contiguous counties, but you have to serve the whole area that you're in, the county. You have to be available for those referrals. And that doesn't happen, we know, in places. And let me just back up and say, we know we have some good providers in California and Nevada and Arizona and Texas. There's no doubt. But we have a lot and a growing number of unscrupulous providers who are targeting certain demographics and only trying to see those demographics. And that's giving us a black eye. And I also put a little bit of blame to the state of California and others who didn't regulate this fast enough to allow that many Medicare certification numbers to come out of one building or one address over 100 or 200. Shame on that state. That would not have happened in my state, and it would not have happened in Florida.
Yeah, that's well said, Tim. You know, our mutual friend, Dr. Ira Bayak, I love this phrase that he has kind of coined because we're so collegial. You know, hospice is such a caring field, and so we have good-hearted people. But he said collegiality ends at criminality, and I think that's a very sticky way to kind of call that out. And I've repeated it over and over again. Courtcaster and I quote it frequently.
Don't miss part 2 of Protecting Patients at the End of Life, Why CON Still Matters, with our guests Paul A. Ledford and Tim Rogers, dropping this Friday, January 30th.